in detail. But now the second part is what we are now sharing, is the slides of some of the parts that would have seen in the text. We have combined everything, the GI and the accessory organs. That is the hepatobiliary system. Yeah. Because it is all part of the digestive system. Okay, so starting with our logo there. Can you see my screen that I'm trying to share?
Yes.
Okay, thank you. This is just a responsibility. I'm accountable for the mistakes that might arise and ownership of the images that I'm about to show. This is an image of Opg Orthopantomogram, where we look at the maxilla and the mandible with the entire set of the teeth. So this is the entire dental formula. And of course, we can look for all pathologies from dental caries to periodontitis to tumors, either of the teeth or involving the maxilla and mandible. Of course, we have also got intraocular radiographs that show one or a few teeth at a time. And it has got a lesser dose. This one is a tomograph, just like CT, so it takes a long time to do, and therefore it has got higher radiation. But of course, more benefits. Okay. This is a procedure called a cielography. We are imaging here the parotid gland. And this is the parotid duct or Stensen's duct, and these are the branches in the gland at the angle of the mandible. This is an oblique view. The mandible is U-shaped. So for us to be able to see one or the other side, is important for us to take an oblique rather than a lateral. A lateral, the two sides would overlap, and therefore would not see detail of any one side. Okay. The other view for the mandible is an AP view. AP view and oblique. Here there is sometimes when we are studying the digestive system, we investigate anything that can befall it. For example, in children and adolescents, sometimes through many other reasons, some anxiety reasons, they may swallow foreign bodies, and we may want to track them to see where they have reached. So here, the idea was to make sure that the esophagogastric junction is covered, because the patient was feeling pain around the sternum. And now we can see some foreign bodies below the left hemidiaphragm. radio opaque items or opacities, and they were actually keys. Some of them were keys, and some of them were parts of a bicycle tire tubes, where we inject air when we are pressurizing that valve. There are some objects that are used to seal the valve. These are what is being demonstrated. So this means that it has already passed the esophagogastric junction, which is the narrowest part of the entire GI system. So if they have already passed that narrowest point, so long as they are not sharp and they not perforate anywhere, they will exit eventually. Yeah. And we can also see gas in the stomach, the fundus, the body, and what looks like the duodenum. Yeah, further proving that these are, some are in the stomach, some are in the jejunum. They are on their way out. So we just give it 24 hours and we repeat another one of the abdomen. If we don't see anything, we assume it has passed out in fecal material. This is a similar patient who had swallowed a coin. We are seeing it in profile. It was a 50 cents coin, but it looks magnified here. It has also passed the esophagogastric junction, so it is on its way out. This image is a CT of the abdomen at the level of the liver. We can see the right lobe of the liver, the left lobe, which is crossing the midline. This is like the midline here. Yeah, so the left lobe of the liver ought not to cross the midline, but this one has. So there's hepatomegaly. We can also see a hypodense serpentine-like area. This is a dilated biliary duct. We can use contrast medium to prove this. So this is just one image, but usually we do many. And with the aid of the contrast, we can see many organs. This is the spleen, and this is the stomach here. This one here, part of it. This is the abdominal aorta. These are crura of the diaphragm, right crura, left crura. The patient is uncomfortable. That's why the patient is not lying flat, supine. This is really oblique because of pain in the right hypochondrium. Yeah. So this was a case of a jaundice, and we were trying to find out what could be the cause. Obstructive jaundice, yeah. This image is an investigation of the hepatobiliary system. We can see contrast showing dilated left hepatic duct, right hepatic duct. They are dilated, and this is a common hepatic duct. Common hepatic duct, and in fact, it is also the common bile duct. We can see a space occupying lesion in it. So this was in theater. We put a T-tube. This is the upper part of the T, and this is the body of the T-tube coming out. So that T-tube is put in theater, and in the radiology department, we inject contrast into the T-tube. So it has filled the dilated bile ducts, and it is showing the cause of obstruction is a gallstone. Yeah. Now, some of the contrast is flowing into the duodenum, and the patient is lying supine. So some of it is going retrograde through the duodenum into the stomach. This is the fundus of the stomach, which in a supine position is the most posterior part, the lowest, and therefore contrast will go towards it. And peristaltis will push the contrast through the duodenum, the C-loop, all the way to the jejunum. So this is part of the jejunum. This is normal physiology. So this explains why we are seeing a contrast in the stomach and the jejunum. Yeah, but the lesion is the gallstone in the common bile duct. Okay. This is the examination plain radiograph of the abdomen, AP view. In supine position, the X-ray beam was vertical. We can see dilated bowel loops full of gas, and we can see the pattern periumbilical. We can see the valvulae conventes. The pattern is different from the peripheral one, where we can see hostrations. So hostrations are large intestine, where we can see images of valvulae conventes, that is small intestine. And you can see that even the small intestine can show huge dilatation, can even be larger than the large intestine, but it is really the pattern that will make us identify where we are. Yeah, so small intestine is central, and the hostrations are peripheral. Yeah, just like we know in normal physiology. So this means that, and the gas is all over. The abdomen is, of course, distended. So to know whether there's intestinal obstruction, we need to take a Decubitus view, which is the next image. And the patient is lying supine, and the X-ray beam is horizontal from the X-ray tube on one side, and the image receptacle, the cassette, is on the left-hand side. That's why we have labeled it left. But we'll call it dorsal decubitus. Decubitus always means that we are using a horizontal beam of X-rays. So now we are seeing multiple air fluid levels. We should not see more than 3 air fluid levels in the abdomen. These ones are quite many. We can count in every loop of bowel. We can count, these are more than 10. They are very many. And the abdomen is distended anteriorly instead of being scaphoid like a boat. Yeah, so this is obviously intestinal obstruction confirmed radiologically. This is an image of esophagus after barium meal examination. There are 2 images. one on the left and the other one on the right-hand side. The one on the left, we want to cover the upper 1/3, mid 1/3, and the lower 1/3. Sometimes we can do this by upper half and lower half, such as we have done here. But many fluoroscopic machines can do 3, and therefore the upper, mid, and lower 1/3. Now, it's not so obvious to see the esophagus, but look at these parallel lines, parallel hyperdense lines. And also intertwined in between, there's a black line or radiolucent line. Now, the radiolucent line is the ridge. You know, the esophagus is folded, the mucosa is folded when there's nothing passing through it. And this is just barium that has stained the ridges, the mountains. So the mountains will look radiolucent and the valleys would look white, opaque. Why? Because the valleys will be full of barium and therefore it will be opaque in the image. Yeah. So it just means that the esophagus is normal and collapsed. It can dilate like it is dilating where my arrow is. Yeah. But eventually we expect to see this linear pattern. Yeah, so this is normal. You can now see that in this particular one, it is a barium swallow, but look at the ridges, the black ones are deformed. There are areas that they are dilated, and there are areas where they have been thinned, the ridges. And the valleys are also areas where they are dilated and areas where they are compressed. The eventual effect is that they look like varicosities, such as we see in varicose veins in our lower limbs. So these are actually varicosities in the circulation of the esophagus, which anastomoses with the spleen, the short gastric veins. Yeah, and this happens when there is portal hypertension and there is reversal of blood flow. Yeah, so indeed this was the case, and this is what they can rupture and cause hematemesis. Yeah. The commonest cause would be due to schistosomiasis. Yeah. Barium swallow again. There is holdup of barium at the lower 1/3. This is the gastroesophageal junction. There is dilatation of the proximal esophagus, and there is shouldering, and then narrowing and irregularity in this distal part before we reach the esophagogastric junction. Yeah, so this shouldering and irregularity is a hallmark of carcinoma of the esophagus on a barium swallow. Yeah. So this is a carcinoma of the esophagus. And this is in the lower 1/3. we have always to say at what level. The worst prognosis is in the mid 1/3 because of the related structures in the mid 1/3. And the related structures include the arch of the aorta, the carina of the trachea, and other great blood vessels. Yeah, so the one in the middle 1/3 will therefore spread into those structures, including the mediastinal lymph nodes, and it is therefore inoperable. Yeah, so it has the worst prognosis. But in the upper 1/3 and in the lower 1/3, they can be resected, and then we anastomose with the remaining GI tract. Yeah. Okay. These again are two views just showing a hold up of esophagus, of barium meal in the barium sulfate in the esophagus, shouldering, narrowing of the lumen, irregularity. Some people would call this rat tail deformity. Again, this is characteristic of CA esophagus. This is just another view. This patient, we were doing a barium swallow, and we ended up, the patient would try to swallow, and the contrast would end up going into the trachea. So we can, some of it will go into the trachea, some of it will continue in the esophagus. Yeah, so this means that, and it had been there for quite some time. So this is really, you can see hold up at that level there, upper 1/3. So there is a tracheoesophageal fistula, a complication of CA esophagus. Yeah. Okay, this is meant to show ultrasound of the liver. And this is a normal gallbladder full of bile. It is showing acoustic enhancement, meaning a ultrasound is passing through this liquid bile. There are no echoes in free liquid, and therefore a lot of ultrasound appears to be enhancing posterior or behind the gallbladder. Yeah. So that means that this is cystic. In other words, there is a liquid here, and the liquid is uniform. Yeah. So this is a normal gallbladder. We are in the liver again. This is a gallbladder, but there are multiple hyperechoic areas in the gallbladder with acoustic shadowing. Ultrasound cannot go beyond these hyperechoic areas. So these are actually gallstones, multiple gallstones, and this is how we diagnose them. Yeah, so acoustic shadowing is the opposite of acoustic enhancement, such as we see here. Yeah, so we use acoustic enhancement to know that there is liquid. We use acoustic shadowing to show that ultrasound is being prevented from traversing that structure there. Yeah. So we know that the structure has got high density, such as gallstones here. This is the liver again, gallbladder with a thickened. and the wall here is thickened and actually calcified. That is a sign of cholecystitis, chronic. And what we see next, bile is supposed to be uniform. Where there is a inflammation, among other things, there's loss of function. So the gallbladder will store the bile, but cannot contract when after meals. So the bile salts start depositing, and they form what we call biliary sludge, which eventually with the time will become harder and form stones. So this is what we are seeing here. So the diagnosis here is a biliary sludge secondary to cholecystitis, chronic cholecystitis, and we can see a calcified gallbladder wall. This is ultrasound of the liver. The patient had a right upper quadrant pain. It was swollen, tender. This was a 65-year-old male patient. So we did ultrasound, and we can see the texture of the liver is completely distorted. And there's a mass in the right lobe, which is hypoechoic, and it has got areas extending into the rest of the liver texture. This means it is rapidly growing. And therefore, this is how we diagnose a malignant lesion on ultrasound. The patient, we did a biopsy, and the histopathology result was a hepatocellular carcinoma. Okay, this is what we call a ultrasound, but we are showing duplex, two modes, the B mode and the Doppler mode. So this was a liver transplant, and we were trying to find out if there are any signs of rejection. Here, of course, the transplant that we do commonly is a kidney, and we do the same even for the kidney. We look for potential rejection quite early using Doppler, Duplex Doppler. So here we are interrogating the hepatic vein, and this is the waveform. Yeah, now it is a venous waveform. It is undulating. The reason is because in inspiration, the diaphragm is compressed downwards by the air in it, the air in the lungs. And therefore, intra-abdominal pressure increase, and the diaphragm squeezes the liver. Since it is the largest organ in the abdomen, that will feel the pressure. So the hepatic veins, the pressure will rise on inspiration and go down in expiration. That explains why it is undulating. It is the only vein in the body that undulates like that. So this is a characteristic, a hallmark of the hepatic vein. Sorry. This one again is a duplex Doppler. This one shows two veins. The one below the axis here is a hepatic vein because we can see the undulations. But then there is another one flowing in the opposite direction, which is a smaller vein. Probably branches of portal vein, because there are those two types of veins in the liver. Okay, so there was no evidence of rejection. Now, this other one is barium meal view of the stomach. We do this at fluoroscopy, and the patient is erect. You can see an air fluid level in the esophagus, even in the fundus of the stomach, air barium level. This is the body of the stomach, and this is the antrum. We can see another air fluid level before we see the duodenum in the antrum here. The lesser curvature, greater curvature. These parts are important to be able to describe where the lesion is. This one is normal. The greater curvature has got more rugae, and it looks as rough as this one does. This is now the same patient, barium meal examination. This is a supine view. Now barium is now resting in the fundus, because the fundus is the lowermost point of the stomach in supine position. And the air will rise to the antrum. Antrum now will be more anterior. The fundus more dorsal. So barium will flow to the fundus. These are rugae. You remember what we said, the valleys and the ridges. The ridges look radiolucent. The valleys look flooded with barium. Okay. Now, between the antrum and the duodenal cup, we can see an area here. Usually there's a track, but in this case, it is closed at this moment. That is the pyloric muscle, the pylorus, which is a very powerful muscle that can stop all the contents of the stomach for as long as it wants. And when it opens is when the barium can go into the duodenum, or food goes into the duodenum. Yeah. And you can see actually an indirect sign that this area here is completely radiolucent and no markings there. That is a pyloric muscle. The pyloric canal is the one between the muscle at the center. So the duodenal cup ought to look as a triangle with a base, and the two sides ought to be equal, such as this one. So this is a normal duodenal cup. Many pathologies will distort the stomach and the duodenum, as we shall see. This is a barium meal examination again. And one thing to note is that the stomach is elongated, much bigger than expected. It is stretching all the way to the pelvis. This is the left iliac bone, and the stomach is going all the way to the pelvic fossa. So that is evidence that there's some obstruction. And when we go and look deeply inside, we can see that there is a filling defect on the lesser curvature, extending into the antrum. Similarly, from the greater curvature, there is another filling defect from the wall of the greater curvature growing inwards into the antrum. Yeah. And there's a narrow passage in the antrum allowing barium to continue. So this is the obstruction. And this is really tumor growing from the wall, greater curvature and the lesser curvature. This is CS stomach. This is a 1 hour after ingesting barium. Even when we followed at 3 hours, nothing had gone beyond the stomach. So this is pyloric or gastric outlet obstruction. And the reasons could be many. Chronic duodenal ulcer, gastric tumor in the antrum, such as the one we have just seen, etc., etc. This is an image, barium meal again, but now focusing on the duodenum. This is the antrum full of air, and this is the duodenal cup. It is distorted and narrowed. Look at the first part, really narrowed compared to the second and third parts. In the first part, from the wall, there is a growth narrowing the duodenal diameter. And in that area in the wall, there's a niche with the barium in it, which is a constant in all these images. So that is the ulcer crater. And what we are seeing here as a thickened wall is edema surrounding that ulcer crater. So this is an acute duodenal ulcer. And it is also causing narrowing and partial obstruction. Yeah. So this patient will vomit. This patient will have epigastric pain, of course, and with the obstruction of the upper GI. The treatment here is medical because it is acute. This is another patient. We are focusing in the same area. This is a antrum. That is the first part of the duodenum. So now that triangle is represented by just a string-like narrowed structure. Look at the second part of the duodenum. This is the diameter that this one should have. So this means it is chronic duodenal ulceration, and now there's a stricture. We see it throughout. We take many views so that we don't miss anything in one view. Yeah. So this is chronic, and you can see with this narrowing, this stricture, obviously there is some obstruction. And now the treatment here is surgery. We remove this narrowed part and anastomose the remaining GI system. Yeah. So it is important to say whether it is acute or chronic. This is acute duodenal ulcer. See, it is deformed. This is a duodenum. It is only in one view that it looks almost normal, but it isn't. This side is longer than this other side. This is the base, which is also irregular. And this is the pyloric muscle that we talked about. Yeah, so this is acute DU. Okay, so this is a barium meal and follow through. So the follow through, we have done a meal, but we go ahead and follow to see the jejunum and the ileum. You can see that the mucosal pattern of the jejunum is feathery compared to the one in the ileum, which is completely different. We can see the same valvulae connivente, but the pattern is different. So we can always tell whether there is rotation or malposition of the jejunum or ileum. Yeah. But this one was normal. This it should be. The ileum is much, much longer than the jejunum. For obvious reasons, most of the absorption is in the ileum. And the villi, which really are tools of absorption, are in the ileum. Hence the difference in the pattern. The commonest indication for this would be malabsorption. And you know how malabsorption presents. The stool will not be well digested, so it will be bulky and foul smelling. And it will float in the toilet. It will not be easy to flush. Okay. This is a barium enema. It also happens to show some pathology. Look at the hostrations in the cecum and the descending colon. The transverse colon does not have hostrations, even the descending colon, up to the rectum. This particular disease, which is ulcerative colitis, extends from distal and it goes proximally. Yeah, so it has not affected the ascending colon and cecum yet, but untreated, it will reach there. Yeah. So this is how it will look like with a double contrast, that is air and barium view. This is on evacuation. Post-evacuation, you can see what we call the lead pipe deformity. See how thin the descending colon now looks like. Where the ulcers are, it is too painful for hostrations to form. Yeah. Okay. This is a CT of a patient. It shows distension. This is low density area, which is demarcating the skin from the liver, which is also shrunken in size. This is ascites. This is how ascites looks like. So this is ascites is under tension, and this is the stomach. You can see the different walls. It is collapsed, so it looks like a very thick muscle. In fact, it is very muscular. This is the spleen. These are the crura, diaphragmatic crura. This is a calcified abdominal aorta. And this is a vertebrae body. So this shrunken liver, this was a liver cirrhosis. This patient presented with abdominal distension We did this CT, and we found a hypodense cyst, which was quite large in the right lobe of the liver. Look at the liver. The left lobe has been pushed all the way to the left costal margin, hepatomegaly due to this cyst. These are rugae in the stomach. This is an enlarged spleen. Yeah, so as we were doing the topogram, we noticed that there was another lesion in the right lung. So we sectioned, we did CT of the chest too. And what we saw in the lung gave away what this is. Yeah, so in the lung, we saw water lily sign. Yeah, we saw a cystic hypodense lesion with an air fluid level, but the air fluid level was not straight. It was wrinkled, such as we see on a water lily. The water lily, when it floats on the water, and you are to do a section through the water lily leaf, you will not end up with a straight line. You will end up with a up and down line. Yeah. So that is a hallmark for hydatid disease. So this was a hydatid disease, and the patient was from the area, Turkana, West Pokot area. Again, hepatomegaly with multiple hypodense lesions. Some are calcified. So this patient had a liver metastasis. This is a stomach here with the air in it, and we can see rugae and even contrast, oral contrast, to help us to define where the stomach is. And this is the spleen. This particular patient presented with a swelling in the abdomen. We did an ultrasound, and whoever reported it said it was a cystic mass arising from the pelvis and extending to the epigastria. So the one who had requested was not satisfied. So we did a CT, and we found that this is the right kidney, this is the pancreas, head and body. So there was a cystic mass arising from the body of the pancreas and extending all the way to the pelvis. It was a huge cyst. So this is the typical. We can see it is hypodense. It is full of liquid. This is a pancreatic pseudocyst. That's how it looks like. And this is one of the complications of acute pancreatitis. Chronic pancreatitis is complicated by having calcifications, multiple calcifications in the body. And when we do an image, we see the calcifications, and the pancreas shrinks into a smaller organ. In acute, it swells. It is inflamed, becomes bigger, and pancreatic juice drainage becomes a problem because now it is not functioning properly, and it continues accumulating and accumulating into the pancreatic pseudocyst. Yeah. Okay. This is a radioisotope imaging of the liver. You can see the shape of the liver here, different views. anterior, oblique, lateral, etc., etc. And now we can see they are called areas, multiple called areas, and only a few areas where there is normal function, normal uptake. So where there is no function means one thing, that the liver cells there are not functioning normally. This was so cysts can show the same cold areas, even malignancy. So these were multiple metastases. Yeah, this is just KICC. We were holding their East African medical equipment scientific conference, and it had been opened by 5 heads of state of the East African community at that time. Now there are probably more than 5, but there were 5 at that time. When this was built, it was meant to show an African heart and the touch, how it is touched, and so on. So African design. So that is the end of our presentation. You are free to make comments or ask any questions.
Allow me to ask a question.
Go ahead.
The last image that was for the liver,
Yes.
I honestly didn't see much. I only understood the first image, but all the others seemed very hard to see and even understand. Can you kindly go through it once more?
Okay, so the last image,
Yes, that one.
okay. We use a gamma camera. Sorry. We use a gamma camera to take that image, and the gamma camera is similar to what you see in theater. When you go to theater to operate, the lighting at the top to make you see the area of operation better. That is now like the camera, and the patient is lying, let's say, supine and turns in different positions. So that camera can take anteriorly, like here. The patient can turn with the left side facing up, so something like this. The patient can turn oblique, and so on. The idea is that we want to catch liver function in all areas. And since the camera is at the top, it will only catch radiation coming nearest the camera. So if you want to see the posterior part of the liver, the patient must lie prone. Yeah, so that is why these shapes vary. But now looking at this one, assuming that this is supine, this is left and this is right. Where there are black areas, that is where there is function. Where there is completely nothing, it means no radiation is emanating from there. So no radioisotope has been taken there. So in your mind, you know that the liver looks like so. Yeah, and now we know that the cells that are functioning are only this part. So then these parts that are not functioning, something has gone wrong. And we are saying that these are multiple metastases, but they can also be multiple cysts, because cysts are just full of liquid. There are no blood vessels there, and therefore radioisotope will not reach a cyst. So anything that cannot take radioisotope will look cold. Anything that is normal will show normal pattern, normal uptake. If too much is taken, such as here, we call it a hot area. So a hot area just means that there's more blood supply than usual. So it could be a benign lesion. A malignant lesion, the cells are abnormal. There will be no proper function, no uptake of radionuclide. Yeah, so in radioisotope imaging, cold areas is what show malignancy. Hot areas will show hyperfunction or some benign lesion. I don't know whether I'm clear.
Yes, thank you.
Yeah, yes. And we usually don't see radioisotope lesions by themselves. You know, radiology department have got all these machines. So we'll start from the simplest to the most complex. And you know, we do many things in the radiology department. It is not only treating the patient or diagnosing only. We also want to see it in all its views. In other words, we do clinical, we also do research, et cetera. Yeah. So sometimes we don't even charge these expensive, tests. We just do them so that for research purposes, we know how the same lesion would look like on CT, MRI, and PET-CT. Yeah. Any other comment or question? Okay, then, in absence of further questions or comments, so thank you very much for listening attentively for the last 1 hour. You read the text. If there is any question, ask it next time when we meet. I believe there is one more session, chest and radiation protection. So I'll send you radiation protection text and also the slides of the chest earlier, but we'll cover the images because it is easier to explain the images the way we want you to discuss them. So thank you very much. Group rep will meet as usual and set the date of the next topic discussion.